Є.
Добрий вечір. Пані Оксана, чи ви мене чуєте?
Так, добрий вечір, пані Катерина. Чую і рада бачити.
Good evening, Jörg. Good evening, Sven. Добрий вечір всім. Ми розпочинаємо. Пані Оксана, вам слово.
Дякую. Я сьогодні відкриватиму і матиму декілька слів для наших учасників. Вітаю всіх учасників, колег, партнерів. Щиро і тепло. І рада зазначити, що це вже 6-й вебінар з циклу тих, які проводяться в проєкті спеціалізовані послуги для дітей та підлітків у сфері ментального здоров'я. І цей проєкт присвячений тому, щоб дати сучасні знання і доступ до найкращих експертів в світі, фахівцям з України. Цей проєкт є частиною всеукраїнської програми ментального здоров'я ТИЯК, яка ініційована і впроваджується завдяки ініціативі першої леді України Олени Зеленської. І дякую нашим партнерам за підтримку UNICEF Україна, Єврокомісії і особливі слова вдячності президенту Європейського товариства дитячої та підліткової психіатрії, професору Йоргу Фегерту. Пане Фегерте, вітання вам щирі, тому що пан професор зібрав флагманську групу експертів з усього світу для того, щоб ми мали цілий навчальний курс, цілий цикл вебінарів для українських фахівців. Сьогоднішня тема буде присвячена проблемам психічного здоров'я, які сьогодні турбують багатьох і фахівців, і батьків, які стикаються з такими проблемами у своїх дітей. Мова йде про розлад аутистичного спектру. Матимемо честь спілкуватися з провідним фахівцем нейророзвиткових розладів, професором наук про психіатрію дітей та підлітків у Департаменті здоров'я жінок та дітей Каролінського інституту, що знаходиться в Стокгольмі, в Швеції. Це професор Свен Bölte. Вітаємо вас і дуже раді, що ви доєдналися до нашого навчального курсу. Професор Bölte є також керівником Центру розладів нейророзвитку. Ми бачимо це зараз в заставці на екрані. І нагадаю, що всі учасники матимуть потім доступ до адаптованого з перекладом відеоверсії цього вебінару. Традиційно у нас велика кількість учасників. Зараз бачу в Zoom 100, а буває і 300, і до 400. Тож сьогодні нам дуже продуктивного вечора. І головне, щоб він був тихим, без ракет і дав нам спокійно попрацювати. Дякую всім.
У вас стоять обмеження 100 учасників.
Я чую когось з учасників і чую, що вони кажуть, що там є обмеження.
Обмеження на конференцію 100.
I understand we are waiting for more people to come in because there's a technical limitation to 100. Perhaps while we are waiting, Oksana, Zbitneva, thank you very much for your very kind introduction, and you already introduced to our speaker, Sven Bölte, but while we are waiting, I just wanted to tell you all that I met our First Lady at her reception last week in the Castle Bellevue in Berlin, and she did a speech about the last year, and the first event she mentioned was our meeting in Berlin, where Kateryna and you and I met to develop this idea of a common webinar. And she asked me to greet everybody in the webinar from her heart and to transmit the best wishes of our First Lady in Germany. Now, I hope that we are ready to start. Now, in my screen is still 100 participants. We never had that problem. I hope that we get some technical advice and can start soon.
Just let me know whenever you're ready. I'm ready. So
I'm ready. I'm just trying to bridge the technical problem, but I think for those who attend, we should start now. Sven Bölte. I met Sven Bölte very early in Frankfurt, and then he went to Sweden. And Oksana already talked about his career. He is a distinguished professor of child and adolescent psychiatric science at the Department of Women's and Children's Health at the Karolinska Institute. And I think, Sven, the floor is yours now, and those who can't attend now will see it on the registration of that program.
So thank you very much, Jörg, and thank you very much, Oksana, for this possibility. Welcome everyone to here. Thank you for giving me so much of your valuable time and attention in these difficult times. And the idea is today to give you kind of an overview where we are in autism, but also looking back where we come from. And I'm then trying to give some kind of idea where we may be heading to. And well, I think round about 1 hour for this, and I often have a lot to say, and I do not want to make this too fast because there's also a translation. And but let's see how all of this works. This is some kind of overview so that you have an idea what you will be hearing about. I'm just saying just 1 second about my center, not too much. And then there will be a lot of things that I have organized around this topic. So about autism yesterday, today, and tomorrow. And sometimes I will do some kind of deep diving into some of the aspects that I'm talking about. And sometimes it will have more depth, and other time I will need to stay a little bit on the surface. And I hope we'll have time later on for some questions. So if there are some pressing issues, please ask your questions. I think there may be time for these afterwards. So I guess very important is also to know that this talk is given by me, and it's a complex field. There are many things happening, and there are also many attitudes. We maybe also sometimes have research that's not 200% consistent, and traditionally we have a kind of biomedical model in autism, but there's a concurrent model today around neurodiversity and diversity in general. And these two models, we need to handle them at the moment kind of in parallel. And so there's a little bit of controversy in the field of autism, and my hope is I can give you some kind of a balanced view on things. That's the aim. But it's good to know I've been working in that field for 30 years now, and first in Germany and Sweden. I'm also having an employment in Australia across different disciplines, and so and I'm a psychologist by training. So that's my background, and then another person would maybe give you a slightly different idea of the field. So I'm chairing this center at the Karolinska Institute. It's a collaboration between the region of Stockholm where healthcare is organized. So we have a child psychiatric outpatient department, but we're doing a lot of research and development. And if you want to know more about us, you can visit our homepage. One thing that's maybe interesting for you is that we also have a lot of open webinars, and there's also other resources in terms of movies and films and so that you can have access to. It's all free, and quite some materials also there in English. So if we start just generically, I would like to try to give you kind of a brief summary of what we think of autism today. So there is some kind of growing consensus that autism is an expression of kind of neurological diversity, but that it also comes with a quite a high risk for co-occurring both somatic and psychiatric conditions. And that what autistic people mostly kind of struggle with is that they feel there's a mismatch between kind of their behavior and their way of perceiving things and well, the demands and expectancies of society, and that this is present in very many different areas of society. Everything from school, but also at home and leisure and at work. So it comes with a qualitative impairment in how you can conduct your daily living. It's predominantly genetically predisposed, but there's also some space for mostly also non-shared environment. And if you want to get a good idea about autism, it's quite important that you have an understanding of the cognitive alterations that are underlying. So mostly executive functioning, but also social cognition and self-regulation and other issues like attention to detail. So if you have a good understanding of those cognitive alterations, then I think you can be quite sure that you have a good understanding of autistic behaviors. And what we try to achieve today is mostly preventing from negative outcomes that can be attached to autism, but not necessarily must be. And that's, for instance, school absenteeism, which is a rising problem in many high-income countries. With autistic children, they kind of refuse to go to school because they do just not feel that that's the place where they want to be. Later in age, of course, we have high unemployment rates, which is a problem. It's a high rate of mental and somatic illness. And then just in general, autistic people do not achieve a comparable quality of life. And often they also acquire some unhealthy lifestyles, and maybe some of people have a high degree of loneliness, which we know is a very unhealthy thing to have. So the interventions today focus on trying to achieving those goals. Something that's important is psychoeducation, to get a good idea as an autistic person who you are, what your strengths and difficulties are, what gives you energy, what takes energy, which contexts are places, situations where you feel well and accepted and the way you can functioning well, and what makes you feel sick and excluded. And also training up all of the environment of the children, everything from, of course, parents and siblings, but also the teachers. And I guess we also want to have a different approach by the society as a whole. There are cognitive aids, to help people, getting their cognitive functions working better in terms of apps, but also in acquiring other cognitive strategies. There's the idea that also the environment must do quite something, so that we try to achieve some kind of inclusion in the workplace or in the schools, that the environments try to help autistic people to function better, to feel better, and make it possible that they get new learning opportunities and other learning opportunities, and that we also address the comorbidities that are often visible, so that we try to work on the mental health of people and also detect and adequately treat their somatic health conditions. That we get a little bit of a new idea about things in terms of not only focusing on the deficits of people, but also trying to find out, do they have any resources and strengths and interests, and where's the motivation, where the preferences, and can we also work with those? So trying to get a little bit of an idea of positive psychology, which does not mean everything is great and everyone can achieve everything, but mostly in the lives of people, there are also positive aspects. There's some things that are working out, and the idea is, can we also trying to increase the amount of the things that are working out and not only trying to work on the things that are not working out. Well, there are guidelines now. It's kind of a standard. Different countries and organizations publish guidelines, which is a good thing, just to try to get some kind of standardization in the way that we approach and view autism and how we do things, and some kind of international standard. Often people look at the guidelines from the UK, which is the NICE guidelines. Also, of course, because they come in English and they are therefore accessible for a lot of people internationally. So if you want to have a look at English guidelines, the NICE guidelines in the UK, and they're freely accessible, is always a good place to start. In Sweden, we also have guidelines, just newly published ones. They are not so much directed to professionals, but they're a little bit more directed to decision takers and people who head organizations and also policymakers, and giving kind of rather broader recommendation. What are kind of the most reasonable things to do also strategically? And one, of course, is about kind of fostering and trying to develop early intervention, and also kind of planning ahead. I mean, if you start some kind of intervention, you know, what can you do next? What will it be leading to? Are there other things that you should be doing afterwards, and who you need to involve? So really make kind of a long-term planning. And also that people should not always wait for a formal diagnosis when there is a suspicion of autism, and sometimes that suspicion is quite easy to make, especially in more severe cases. Then people in preschool, in school, and other places should be trying to deliver support and other things, also without waiting for a diagnosis, which is sometimes today a process that can take quite a lot of time. We have still good deal of potential for improving the coordination of different services. Autism is something that is relevant for many different organizations in the municipality, in the region, or on the federal level, and often they're not talking to each other a lot. Sometimes professionals are not talking to each other a lot. So trying to develop the coordination of services. And then we also have groups who have a very hard time to reach services. In Sweden, that's, for instance, group who not are ethnic Swedes, but have an immigration background. And sometimes in child and adolescent psychiatry, also in neurodevelopmental disabilities, we have a hard time reaching these groups because there's still stigma. They do not understand the system, or there are doubts about, you know, or maybe just they do not like to approach public services because they maybe have negative experiences from their own home country about this. And I think it's also very important, especially in this area, that we look, you know, what the target group is thinking and what are in interest organizations thinking about the field. There's been a development that we have a little bit of a kind of divergent development in that field. Professionals and people who are diagnosed and parents maybe do not always kind of want the same thing, or have different ideas about things. And it's important for us professionals that we know what autistic people think and what their ideas are, and what interest organizations think and what their priorities are. And I think, for instance, the National Autistic Society in the UK is a very good and very balanced interest organization. And please have a look at their advice and guidance for autistic people and relatives. I think it's also a lot of good guidance for us as professionals. Then, well, there's so much to read nowadays, so many publications coming out each day. I'm always trying to recommend not too much, so I'm recommending this to you. This is the Autism Commission published by The Lancet, just I think 2 or 3 years ago, and that's something where a group of professionals and researchers get the opportunity to make a description where the field is at the moment and where it's probably going to head to. And this is a co-produced paper. So it was not only researchers and clinicians, but also people from interest organizations and autistic researchers. So it's really kind of an attempt to generate a good consensus for today and also for the future. And you can see, because I will not be able to go through everything, you can see there's a very good summary of the diagnostic instruments and the diagnostic approach. And there's, for instance, also good summary of what kind of interventions are recommended in which ages for which arenas, and that's what you see there down to the right. These different bubbles are different. These different bubbles are different arenas, and there's. Just wanted to give you one example because we're also working a lot with this. Something that is recommended across ages, everything from childhood via adolescence to adulthood, is social skills training in autism. And of course, it appears logical that you would like to train some kind of social communication in a condition where social communication problems are a main challenge. So just as an example, a program that we have developed that was during my time in Germany, but then we have worked with this for a long time, for almost 20 years now, is the training Contact, which is social skills group training that comes in different length, where you train children and adolescents, everything between 1 to 1.5 hours a week, where you have 2 trainers and 6 to 8 children. And it applies a lot of different methods, for instance, CBT, but also behavior activation, acceptance commitment therapy, cognitive training, observation, learning, and also peer support. And typically in such a training, you follow different principles. For instance, you have a clear structure, you give a lot of information in an understandable way. You make a kind of agenda for the day. You really have a consensus with your group, how you want to work together, what you want to achieve together, and what kind of behavior you want to have in that group. There's a lot of repetition so that really things do not get lost as feedback from the group. And we particularly have not only general aims, what children and adolescents would like to achieve, but also there's a lot of personal aims. So we really try to ask the children and adolescents, what would you like to achieve in your social communication in your life every day? And we also try to achieve those personalized goals during the intervention. And of course, we need parent involvement. And what we do foremost is also trying to motivate the children themselves and the adolescents that they really would like to go the group and that they do not feel that someone forced them into it and that they are sent by their parents and that they maybe need to do something that they actually do not like. So really trying to generate this intrinsic motivation and having a spirit of developing together. And for instance, those groups, they have an opening session and a closing session. There's a parent involvement, of course, that's mandatory elements. There are recurring elements that we talk about the goals that the children might have. They get homework, and sometimes we also need to repeat the policies. And then the core of each session is that there are things like group discussions and role play and group activities and other forms of training and repetition. And the longer we come in that training, the more also not only more advanced are these discussions, but also more and more the participants have an influence on kind of what they would like to particularly focus on during the training. And this has had a lot of kind of spreading internationally, and we also have data from different countries. And just kind of briefly mention if there would be any interest in the Ukraine to have an adaptation for your country, of course, open to it. We can see that we have good outcomes, especially when we train 24 times. It's maybe apparent that when you have severe challenges in the social communication area, that this is not a quick fix. So our results are mostly showing that you need at least 24 sessions to come on a certain level. But then we also see, for instance, for social cognition, for social awareness and social communication, effect sizes on standard measures of around kind of 0.80, which are considered large effects. And we see also on other measures improvements, for instance, for quality of life. We see also that we can conserve this effect also when we test against other kind of group intervention. And another thing that we see is that girls maybe have a little bit more benefits than the boys, the adolescents a little bit more than the children. And we can also see that certain gene setups can predict if you are doing well on these programs or not. And just to finalize this short kind of excursion around this, I just wanted to show you this film. I hope we have sound now. Yes. Can you hear something? Do you hear something? No, then I think I do.
Well,
I do this quickly. I do this quickly. I need to do like this, and then like this again, and like this. And let's now see if you hear sound. Better?
Contact is a
Yes.
social program for children and teenagers with autism spectrum disorders. It aims to build their social skills and then support them to generalize that to their everyday lives. I've never really been good at social stuff. Doing Contact made it a lot easier to keep in mind the dynamic of the people around you, to just kind of remember that you're not the only person in the room.
Before I did Contact, I was very nervous around other people. I hardly talked to them. I didn't want to talk to them. And now, like, after, I feel like I still feel nervous, but I feel a bit more confident being around them and talking to them.
People can come together and be themselves and feel safe and accepted. It made it a lot easier to connect with people.
It was the first ever activity where my daughter has happily gone every single week to. For her to come out every week with a smile on her face told me that it was something really special.
When they come in for the first time, they're really not eager to talk to me or discuss things. But the second time that they come in, I can see that they're just talking and they just want to tell me about everything that's happening in their life.
We teach everything from social rules and norms and how to read others' minds and intentions and emotions, and to conflict solving.
I think it's given me a lot of perspective on kind of how to interact with others in a group scenario, which is what I needed going into it, I think.
I feel a bit more comfortable and like knowing what to say and stuff.
It's all about having the confidence. When you go to find a work, you need to be able to talk about the abilities or the strengths that you have. If you want to come to uni, it's about being able to move around in a big social environment and just coping with it.
In planned social situations, I'm yards ahead of where I was before I did the group.
For her to be able to break that down and understand where those difficulties were, and that it was okay that some things were difficult, and this is why, and this is how I can do it different.
It's just giving them more tools in their toolbox, so when they're in a social situation and they just needed help, perhaps they can use the tools.
So we're going to have a lot of data to really understand what's really going on in this program, what sort of interventions we can develop going forward for teenagers with autism that are really, really effective.
The more we understand and the more we help them, I think the world in general is just going to benefit hugely.
The thing that made this research really possible was having a big funding so we can give the program to the kids for free.
It's been key. Without this funding, we would not be able to do this research. Undoubtedly, we would not be able to do this Contact study. It's hard to put into words how grateful I am for the funding.
The donation makes Contact.
I stop here because now there's only a lot of thank you for the funder who made all of this research and the clinical application possible, but gives you an idea just of one intervention, kind of one method that is used across many countries, that is becoming a standard, especially in adolescents and young adults with autism. And one thing that we also found out was, while we were implementing this in the clinical setting, that a lot of children, adolescents, and parents that were requesting that such a form of training should also be available in a more naturalistic setting, that it should not only be provided in a clinical setting. So that's also why we and others have adapted such a originally clinically meant programs to the school. So this program and others are also been adapted to schools where you can train in a naturalistic setting, where you maybe get a good generalization of skills, where you also achieve that the teachers know their students better in a different context, and they develop some kind of relation together, and that so that they spin off for the knowledge and the skills that schools and teachers have. And importantly, also here for this training, it's not mandatory that you have an autism diagnosis. You can also have a suspicion of autism or having autistic traits. Well, and again, we have good evidence that this works good in schools, and we have also very nice reports from teachers who think that such a program can give a different school climate. People start interacting differently with each other. Okay, but let's talk a little bit about where we come from. So when I started, autism was considered to be a rare condition. We talked about per mil, so some in 1,000, and autism was mostly considered as a very clinical phenomenon. And we thought that diagnosing it was very simple, that you could do a diagnosis almost in the waiting room, and that a diagnosis of autism would kind of cover everything that's in the picture, that it was such a comprehensive diagnosis, you would not need to diagnose anything else almost. Autism was also stigmatized a lot, and it was connected, or it was thought to mostly be connected to intellectual disability, that it was a condition far more prevalent in males than in females, and it was a limited interest. It was really a child psychiatric condition, especially in adult psychiatry, or in school, or kind of even in the business world. This diagnosis was nothing that people really cared about. And autism was thought to be a categorical phenomenon that you either do have or do not have. And people thought, well, the goal of autism treatment must be kind of to cure autism. So that was, all of this was our default at that time. But when you think about autism today, it has changed quite a bit. Today we're talking about percent. So, and we are in the area of having some percent of autism across ages. Even though these figures are kind of a moving target, these figures are not very stable. They're mostly still on the rise in many countries. We also think, probably also connected to this, because we're seeing people with lesser autistic traits, that assessment not always is so easy. So no one would say anymore that you can do all of this in the waiting room, but especially in people who are somewhere in the milder end of the autistic spectrum, it's not so easy always to see if that is really autism, or maybe a variant within neurotypicality, or maybe something else. There's also a trend of diagnosing a lot of different things in autistic people. So not only autism, but also other conditions, if people think that is needed to describe comprehensively the person. There's a huge interest about autism from many, many places now, also from the public, because so many diagnoses, it's getting kind of a very interesting topic for many different places. There's more and more guidelines, there are diagnostic instruments, they're often required in the diagnostic process, or is it expected that the clinical judgment is kind of backed up by standardized instruments. We have a lot of more diagnoses in women than girls today. Diagnoses are made earlier, but also not in adults. Autism is considered as a kind of continuum of traits. But in the extreme end of the trait, that's where we normally kind of meet people in the clinic and where diagnoses are made. There's also the idea that the environment needs to do quite a lot of things to help autistic people to functioning better. Not that necessarily autism is always need to be cured, and it's always only the kind of the duty of the autistic person to try to be better and try to give everything to make it work in reality, but also that the environment has responsibility. Then we talk a lot about autism and health, kind of mental health and somatic health. A lot of autistic people think, and I agree when I see the people who also work in my center who are autistic, the biggest problem is their mental health and sometimes also their somatic health. They have often a mixture of different things. It's hard to differentiate a mixture of depression and anxiety and kind of feeling of being, you know, exhausted and stressed. So, and that's often very, 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 very heavy on their shoulders. So that's often their largest concern. And then something that's also happening, which I think is important for professionals, is because there is not only professionals at the moment, but also society as a whole talking about autism, and especially also people who are diagnosed and their relatives. They are coming up with their own ideas about autism. They're coming up with their own concepts about autism and have, for instance, you hear a lot of concepts that maybe clinicians are not using. For instance, masking, or kind of autistic burnout, or hypersensitivity, or pathological demand avoidance. So concepts that not necessarily do not come from professionals, but are very, very popular in this population. So it's something that we need to be aware of, and what is meant by it and how we handle it. The development is also, I'm not exactly sure how this everything is in Ukraine, but for instance, in Stockholm, where I work, and I think in many other high-income countries, we can see that this field, especially autism and ADHD, even though, of course, its prototypic form is something completely different than autism, there we see kind of a parallel development, for instance, in the increase in diagnosis. And there's also high co-occurrence of these two conditions. But nowadays we can see about 50% of the referrals and the resources in child psychiatry in Stockholm is going to these two conditions. So it really has increased in just the amount of referrals and the people that come for these with these questions. I'm sorry, there's a little bit Swedish in here, and we do not need to go into this into detail, but it's just giving you impression here. For instance, to the right, for autism, across the sexes and across age groups, we are somewhere between 1% and 5% in child psychiatry. These are figures that are very much higher than we have thought, and these figures are still on the rise, at least in Sweden. Another important aspect is also that we see that the amount of people who, or kind of we can see in different municipalities of the region of Stockholm, we can see that there's they really differ in terms of in which part of the city people are consuming services or seek help for these diagnoses. For instance, we can see in downtown Stockholm, where mostly Swedish people live, ethnic Swedes who have a strong kind of good economy and a very educated background. We see there are not so many diagnoses made compared to other parts of Stockholm in the outskirts, where you have, for instance, also ethnic Swedes living who have a kind of a comparatively low socioeconomic status. So there are obviously also some social components who drive not the causes, but drive, you know, if you need and if you're looking and if you're seeking services. Somewhere in the middle here, we have those parts of Stockholm where many immigrants live. So that's a group that is not necessarily a group that we easily reach. Another important theme is, and I talked about this, so classically there was the idea autism is connected to intellectual disability. So, but today the amount of people getting diagnosed with autism plus intellectual disability is quite low. It's maybe down to 20% in Stockholm. So the largest amount of autistic people is in the normative intellectual range. And the increase that we see in diagnosis is almost exclusively in the what we sometimes call the high functioning range. Actually, the amount of people who are diagnosed with autism plus intellectual disability has been dropping a little bit in the last years. What you also can see when it comes to gender distribution and talking about how autism looks like in girls and in women has been a very intense discussion. You can say, for instance, autistic girls, they are often more verbal. They maybe also have a higher social kind of wishes and social kind of desires, and they want to interact. They maybe also have interests that are kind of more shareable, and they often have more internalizing issues on top, which makes that they're often not so easy to detect, and sometimes are detected quite late. So what we can see today, for instance, in Stockholm is among young adults, that's not a child adolescent population, but it comes immediately afterwards. We can see that there's well, the ratios between boys and girls is almost quite balanced. What we can see, the younger the children are, the more skewed is the balance. So autistic girls or women are diagnosed, at least in Stockholm, but they're still diagnosed later. About 3 to 4 years later are in Stockholm women and girls diagnosed compared to male counterparts. Well, a huge question is why we are having more diagnosis today. And this is, I have this box of chocolates here because these are very different hypotheses that maybe can explain why we have this situation that we see an increase. One, of course, is that we are doing more comorbid diagnosis. We are diagnosing more conditions in the same person. We are doing more diagnosis in girls. We're doing diagnosis earlier, also in adults, something that, of course, drives the numbers. There are some kind of diagnostic preferences that have been changing in the profession who are doing assessments. I do not like the word trends or fashion or so at all. But of course, there's some kind of an internal hierarchy, what you're looking for the most, and what drives your diagnostic hypotheses. And somehow autism and also ADHD, there have been, that these hypotheses have kind of, they're higher now in the internal hierarchy of people who are making assessments than previously. There's also a complexity in society that has changed. High expectancies on health, high expectancies of well-being, high expectancies on service use. So people come also earlier and seek help for maybe kind of lesser issues. We had things that happened kind of policy-wise. For instance, in Sweden, a lot of money has been invested to reduce the waiting time for the first visits in psychiatry. And also for diagnostic assessments. And if you of course make huge investments on assessments and not on other things, on prevention or intervention or qualifying of people and so forth, you may be also driving the number. In schools, there have been a lot of changes in school from a more kind of traditional way of teaching to coming more to a way of that children should kind of organizing their own teaching, a lot of group work, project work. The children are supposed to drive, their own education. There's lots of digitalization. So you need a high degree of cognitive skills and also motivation to succeed in school today, at least in the Swedish system. I guess maybe elsewhere too. And that's probably good for a lot of children, but not for the children who have autistic traits and who have cognitive issues. For them, it's getting very complicated. We have also seen that stigma has dropped for autism. So it's not so complicated anymore for clinicians to make that diagnosis in most cases. And also for people to receive the diagnosis. Some people actually are seeking the diagnosis today kind of quite actively. And that's a huge change. We do not have kind of alternatives to psychiatry a lot, or people get referred from these places to child psychiatry. So there's not maybe for some people, for a new kind of level of people, there's not kind of the right kind of service level. So many people end up somehow in psychiatry. And in psychiatry, it is our way of making kind of an issue visible is of course using diagnosis. And sometimes we know if we are not making a diagnosis, people do not get any attention or credibility or help at all. So sometimes also clinicians feel that they are forced to make a diagnosis too, because they know this is the last chance for some families or children, adolescents to get any help. I mean, sometimes there's this diagnostic upgrading to make help accessible. And something that I found very, very interesting today is that at least in our society, diagnoses like autism or even ADHD, these diagnoses or these phenomena, they have been generating some kind of identity for many people. They are connected with a sense of belonging, and they have a positive connotation. So people are also trying to get some kind of explanation and try to connect to each other to other people with similar issues. So it's really driving an identity. It's kind of sometimes a little of a movement. And I mean, we can discuss if that is a good thing or not, but it's a fact that it does not fit very well the idea of a biomedical model, that people actually try to kind of relabel some kind of the things that we use as our diagnostic tools. Yeah, but if you look at, I mean, Sweden is a highly resourced country, but still we struggle also in clinical services with a lot of things. We have done a kind of an exercise where we interviewed a lot of professionals who work in child psychiatry and in pediatrics in what we call the habilitation centers in Sweden, but also the leads of the organizations and parents. And the interesting thing is there's a lot of agreement between the providers and the users that there are things that we should be changing and trying to improve. For instance, the complexity of services or the help also with somatic issues, and that there's also need for more senior people in services. So there's agreement about what we should be changing, but I guess there's not so much agreement how we should achieve it. We can, for instance, see what this mapping exercise revealed was there's a lot of things that service users would like to get, but which is not provided by us. For instance, more individualized assessments, more individualized interventions, something that we do not often, have the time and resources to do. And there's also other data. There's another study actually done by autistic people in Germany showing that a lot of, for instance, psychotherapists, they have a very good idea of, for instance, depression or anxiety, but they're not very well educated and feel not very, very safe to provide a good service to autistic people. So there's also a problem a little bit in competence and in education among service providers in some areas. Well, so clinic is one arena. Another extremely important arena, of course, is school. I mean, if you ask parents or even autistic children and adolescents, they will tell you now that one of the biggest challenges is trying to get it somehow get things together in a good way in the school area. And we have, for instance, looked at if Swedish schools are and if they're doing a good job in approaching children with neurodevelopmental disabilities, and have, for instance, found out that even though there are many decisions taken in Sweden, and I guess there's also international agreements that inclusionism is a goal, you can see that, for instance, not many people who are working in school have an idea what inclusion is or have been educated in approaching autistic children. So there's a good deal of potential for developing schools when it comes to a better and more effective and more kind of friendly approach to the population. Well, something that we cannot ignore, and I think I touched on this in the beginning, is that the idea of neurodiversity is growing bigger and bigger in that field. Probably many of you are aware, but it's a part of the kind of human rights movement, and the idea is, well, autism is not a disease or a disorder, but autism is natural variation. and that there are many different brains in that world, and they can be different by nature. It does not mean that these differences are pathological, and they come with strengths and weaknesses, and that autism is part of this natural variation. And I guess for us, it's most important that that this comes with a lot of critique of how we have been working and how we think about things. Because I talked to you about social skills training, there might, for instance, be a lot of autistic people who say, well, you should not be treating me, kind of in this way. You need to accept me as I am. So everything that's about training, or everything that's about intervening with a person, or a lot of autistic people would think that is kind of manipulation, and that people are forced into something. So I guess for us kind of professions, it's important to know there's a lot of critique out there how we have been looking at autism for a long time. And something that's also important is there's so much terminology out there. It's sometimes hard to know, what kind of terminology you should be kind of using, especially also in the interaction with families and children nowadays, at least here in Sweden. For instance, the idea is that we are saying autism is a neurodivergent condition. So that we say, well, neurodiverse, that's the population, but in the kind of neurodiverse population, there is a group of people, for instance, those who are autistic, or even those who have ADHD, and that's the group of people who have a very hard time, because of their prerequisites, have a hard time to cope with the demands and expectancy of mainstream society. So the critique that often is directed from this movement to professionals is that we kind of have maybe the wrong knowledge, or we do not have enough of knowledge, that we always interpret differences in a negative way, that our knowledge is incomplete, and that many of the treatments that we offer or have offered, that they are kind of aversive, that they are not in terms of tolerance and acceptance, that they're not providing support and understanding, and that we do not ask enough about what people actually want, what kind of help they want, but we just kind of implement what we think is the right way. While a lot of autistic people think, well, they would like help and support, also that they themselves wish and accept. So it's good to know kind of neurodiversity, even though I sympathize with a lot of the ideas. There are also areas where I think people are really actually a lot of overdoing it, and are negative around kind of almost everything that we have worked for and where we also have evidence for. And this I told you already, it's about how we are saying, and for a long time I have been, and I think most of you too, we have learned that we should be using person-first language in that area, so that we say, well, first comes the human being, and then comes the condition, so a person with autism. But as autistic people who are supporting the neurodiversity view think that they're not having something, so they do not have a disease, but they are autistic, some of the people prefer what we call is an identity-first language. So a lot of people would like to be called autistic, not saying that they have autism. And with that comes also that other terminologies are not liked. It's not liked to say ill or effective, or that you say healthy or normal to other people. So there's a lot of discussion around the terminology. I think as long as we know what we are talking about and we're not offending people, it's fine to adapt. But it's just good to know for some people how we say is so important today, that in the alliance that we would like to have with our clients, it can be an important thing, a very important thing. What the community also would like to see is a little bit of change in priorities, for instance, in research and development. For a very long time, a lot of research in the field of autism has been awarded to basic science, to genetics, to brain imaging and other things, and mostly trying to find out what are the problems with autism, what are the risks in autism, where are the biological markers and so forth. While autistic people, a lot of parents would like to know, well, can there be more research on the things that are very important for us every day? So, for instance, how are services organized? Are services organized in an effective way? Is the funding that comes to services invested in a good way? Are medical doctors, psychologists, and other health professionals, how well are they educated in autism? How do schools work? How are they working? How should they be working? And what is the best way for me once I'm leaving school and I would like to try to get a job? Where's the research on these questions? So the community would like to see kind of a better balance of maybe basic research and applied research and implementation research and society-based research. Another important point is we are seeing far more, well, not only autistic researchers, but a lot of autistic activists in that field who make their voice heard and sometimes are critical and sometimes have a different attitude about things. Some of the things that I really do like, because sometimes there is, of course, a point when you know about the perspective of other people. And something that is often put forward by autistic people is the so-called double empathy problem or double empathy theory. And that says, well, autistic people would say it's absolutely true that we have a very hard time understanding not autistic people, and we do have a hard time understanding and reading other people and try to understand what people want from us and to comply with their expectancies and fulfill well, the demands on performance. And so it's absolutely true. But it's also true that non-autistic people, and maybe sometimes including professionals, they do not understand autistic people very well either. So they have a hard time reading autistic people, understanding what they want and how they feel and what their priorities are. So at least, well, there's an idea that we need to consider that things are often kind of bi-directional. It's not only going in one direction. I think autistic people have a point here. Yeah, and something that I think we will be doing probably more in the future is co-create solutions and co-create interventions and co-create research. I think it's important because, well, the community has grown so strong and it's a very complex field. And if we want to invest money wisely, it's probably good if we generate those solutions together too. So that we have different professions from different organizations trying to find solutions, and that we include interest organization, and in this case, autistic people, together and trying to find out what is the best solution for everyone, so that we come up with the results. And when we come up with intervention and development, that everyone is happy with it. And I think we will reach far more sustainability also, and it's probably easier to implement than when it's just driven by a group of people, either policymakers or researchers or clinicians, so that we get a consensus around things. I think it's an important approach, and we work since a few years quite consequently with co-producing everything that we do. It's a challenge. You need to find people who can work together, but I think it's also really worthwhile. And the question is, does that work out? Is co-production really something, co-creation, something that is successful? And I can at least tell you that, for instance, the European Union is funding a lot of co-produced research. There is quite a huge pan-European project called the R2D2 project. It's called Risk and Resilience in Developmental Diversity. And the idea is here that you co-produce. You have a huge group of autistic adolescents, but also adults and people with other neurodevelopmental diagnoses. The thing is mostly on trying to understand resilience in autism. So trying to find the biological, the genetic and kind of brain-based, but also the social and psychological factors that are promoting kind of health and well-being and success in autistic people. So trying to find out, well, what are the factors that make that people with autism stay healthy and have good lives? So what are these factors? Not like we have traditionally done, trying to find out where are all the risks. So and it's really a very fascinating way of doing research together. Yeah, this is another example. It's from former colleagues or still colleagues in Germany. There's the Autism Research Collaboration that has existed for a very long time in Berlin. And what they are doing, for instance, trying to go into those arenas where autistic people think there is a lot of improvement needed, for instance, how autistic people get approached in the job center, or how they maybe get approached by a general practitioner, and how they get approached in school, or how they get approached by psychotherapists, trying to, well, improve those arenas and trying to help people who they meet every day and getting a better idea of autism and how maybe they could help autistic people in a more effective and better way. Well, this is almost my last slide. I think I'm okay in time still. So the question is, where are we going from here? This is just my thought. And I think if I see which developments are going on in the field in different countries, I would say probably we will see kind of a shift from looking a bit less at the causes of autism and looking into a little bit more, the support that autistic people maybe need. So it may be a little bit of a shift from only looking at biology, but also to the social aspects of autism. I guess we will shift a little bit from the idea of a disorder more into the idea of differences, but also not trying to forget that there is also autistic people who have kind of strong somatic and psychiatric issues. So I think we still need both models, both the diversity, but also the medical model. There will be also a shift in the focus that we do not only perceive autism as a clinical entity, but we also see it as a kind of something that should be addressed in a different way by society in different areas. For instance, in school and at work, that we build capacity, knowledge, and a better approach to people who have those differences in many different arenas of society, and that not the society, whenever there is a behavior issue popping up, that they are sent to psychiatry or child psychiatry. We're probably getting better at finding solutions for this population. I found out myself that I have been trained so heavily in being excellent in finding out about all the problems and deficits that people may have. And I'm sometimes a little bit blind, at least on one eye, and seeing at the resources that they have and the solutions that they may are to their challenges. We probably will see autism less as this coherent group, but say, well, autistic people, they are very different, and we also need to have a more individual approach to them. As I told you, I think we are going from a one perspective of professionals and experts to a view that we're trying to co-create solutions, and we're trying to talk more together and trying to find out how we can find solutions together with the target group and hear more what they are saying, what their desires are. That we not only say, well, for instance, in research, where I also work a lot, is, okay, we are doing things that maybe will help you in a 20, 30, or 100 years or never, but also generating evidence and knowledge that maybe helps people kind of very soon. For instance, research on service organization or so. And that we say, we do not only need to address the individual, but we also need to address the individual's environment. So the workplace, how can we do things better in the workplace? What can colleagues do? What can chiefs, what can kind of people do, in the hierarchy? How can we organize schools in another way? And we may be also more interested in the future, not only at reducing symptoms or focusing a lot on the diagnosis, but also say, okay, what is the quality of life of these people? How are they doing? How are they fixing kind of their daily life? How can we organize, their functioning in a better way? And what are their personal goals? What would they like personally to achieve, and how can we help them achieving this? Because I also think there's a lot of the motivation that we need to have to be successful. And then in the end, I think we have, at least in Sweden, we have so many different organizations who blaming each other at the moment that services are not better organized. There are a lot of organizations, sometimes you have the feeling they know a lot better what they cannot offer to the population than what they can offer to the population. So I hope that we get a better kind of organization of services across the region and municipalities and the federal organizations. So, and I hope, and that's something that I'm working with quite a bit, is I'm quite sure that you are familiar that the WHO has a whole kind of little family of classification systems. And I think we have had a very strong focus on using the ICD-10, and well, at the moment or soon, even the ICD-11. So we have a strong focus on diagnosis, but there are also other manuals, especially the International Classification of Functioning Disability and Health. And that's trying more to understand actually how people are living their daily lives, trying to look at both their biology, but also their activities and their participation and how they are impacted by the environment. And I think at least in neurodevelopmental conditions like autism, I think also having more focus on trying to understand the strengths and difficulties of an individual and what things in the surroundings help them or are standing in their way. I think it's a very good thing to do in the future in addition to diagnosing, to get a good ground for intervention and for support. So I think a little bit of a paradigm shift to also looking more at functioning and also not only looking at the diagnosis is probably a good way to put forward. And there are decisions taken by many governments and organizations that is something they would like to do. It's just the implementation is not so easy. So last slide, I think. When I look back about 50 years ago or something, parents who had autistic children, they were trying to organize themselves. They were approaching services, they were approaching policymakers and said, well, we have children here who have huge challenges and we do not see that there's any kind of plan how to help them. And I think it's a lot of thanks to parents and interest organization that we have a level of services today, because they have been trying to work on improving things. And they're still driving, that field. And then about maybe 10 years ago, autistic people themselves, mostly kind of adults, and often also due kind of via internet forum and other things, they have organized themselves and they made their voice heard. And they also make claims, mostly to them also, that this neurodiversity movement and concept has been growing and has developed. So now we have kind of the relatives and parents, and we have people who are diagnosed themselves who have been trying to be very active in developing the field. And I guess what and I call this the first and second wave. The first wave by parents, the second wave by people diagnosed themselves. And I think what they want us, which is the third wave, to achieve is that we are also kind of helping them to get the things in place in the way that they would kind of like to see it more. So I hope we are all kind of in agreement with this, and we want to be part of this kind of third wave. Yeah, I stop here. Thank you very much for your attention. I hope this was not too fast, not too superficial or too deep or something, but it landed kind of quite well in this tonight. So thank you very much.
Thank you, Sven. It was a wonderful presentation, and I'm sorry that we had technical problems at the beginning. Now we are around 400 participants, as we always did, and I'm sure that those who couldn't hear you at the beginning will see it on the video. So we now can have the discussion. Are there any questions?
Was a lot in the chat, but I don't know if these were questions.
Мені треба мікрофон. Ага, все. Can you hear me now, Jörg?
Yes.
I can hear you. I can hear you, okay?
Yeah, we have lots of questions, so I will be reading them in Ukrainian and you will hear what the translators will translate for you. So there were a couple of similar questions. Перше питання з схожих питань від Ганни Ахметчиної. Дитина з розладом аутистичного спектру 5 років не розмовляє. Що рекомендувати? І потім було ще нижче питання від глядачів також, що якщо дитина ще не розмовляє в 5 років, чи можна з цим щось робити, чи є якась надія, що почне розмовляти?
Right. So, of course, a very relevant, excellent question. So I guess the most important thing here is trying to get going kind of some form of communication before we come to language. So get some kind of communication, kind of even non-verbal communication in place. That's something that we can do with, well, often with kind of early intervention in terms of applied behavior analyses. So trying to get some core form of communication in place via kind of non-verbal actions. There are things that you can use kind of images. You can try to motivate the child to use images. You can try to make kind of visualize systems that indicate that certain things the child wants to kind of maybe, I don't know, eat, wants to sleep, wants to look at the television or something else, that you try to find out a different way of communicating, for instance, via pictures that are not language based, and then trying to, well, connect this form of communication to language. That's often something that even kind of behavior therapists can do, and sometimes even special education teachers or speech and language therapists. But the most important thing is to get communication going on whatever level without language, and then kind of slowly introducing single words and maybe kind of two sentences, kind of two-word sentences to get the communication going. And of course, it's very important to expose the child on an average level to verbal communication too. But the most important thing is, I guess, to get the communication going, because that's often something that drives even children crazy, that they do not at least can express their communication. But here's you need people who are skilled in applied behavior analysis, who can identify what motivates the child, maybe also read a little bit what kind of actions children are showing and what kind of happening next, to get some kind of functional idea about the children, how are they obviously thinking and acting, and make sense of this, and then trying to introduce nonverbal communication and trying to slowly develop some kind of speech out of this. But even after the age of 5, there is absolutely a likelihood that children will be able to speak. I know when I was during my time in Frankfurt, we had a very huge collection of families, about kind of 600 families, and we also had people who started talking at the age of 12. So there's still hope. Autism is not a neurodegenerative condition; it's a neurodevelopmental one. So kind of fortunately, you can always hope for or expect that something will mature by the time, as long as you keep going and kind of stimulating and trying to give learning opportunities. So I think that's an important message. I guess I have seen children who are kind of low functioning, and as adults we're kind of high functioning. So it's of course at the of course it gives you kind of a lot of worries when a child is not talking at that age. but it must not be that nothing is ever coming.
Наступні питання в нас були такі. Вони схожі, тому я зачитую декілька. Галина Несмашна питає, було б дуже корисно, якби така програма, як «Контакт», була перекладена українською. Шкільні психологи могли б реалізувати таку програму у наших школах. Наталія Муха пише, чи можна отримати програму «Контакт» українською. Медтайм пише, чи можна отримати інформацію про програму «Контакт», які інтервенції застосовували?
So in principle, I'm very open for helping with the translation. Often we try to do this together with some academic setting. So if there are kind of child psychiatrists or child psychologists who have kind of any form of also academic training, that's often quite a good thing, because we just want to ensure that if we do a translation and adaptation, that the program kind of still somehow, that the principles are saved. But people can approach me, and we have done this for many different settings. We have done this, for instance, for China and for Turkey, where the prerequisites are very different. We always find a solution, and we also find a solution for a specific culture and country. But it would be good if there's some form of kind of academic background for the people who are we doing this together with.
Пані Яна Гош питає, чи розглядається можливість додати в програму використання інших психотерапевтичних напрямків?
Пані Катерино, дозвольте, я відкоментую відповідь. Можу говорити мене?
Ми вас дуже добре чуємо, пані Оксана. Да, говоріть.
Щодо перекладу адаптації програми «Контакт», ми готові взяти на себе таку координаційну роль в цьому процесі. І окремо тоді зв'яжемося щодо того, як це найкращим чином зорганізувати. І з паном професором Фегертом і з паном професором Bölte для того, щоб для українців був доступним цей продукт. Думаю, що наступного вебінару ми зможемо нашим учасникам вже сказати про те, як це буде виглядати. Тому координаційний центр дуже підтримує такі проєкти. І нагадаю, до речі, що МКХ-11 вже перекладений українською мовою і доступний. Будь ласка, користуйтеся.
Дякую, пані Оксана. Тоді ще раз зачитую питання від пані Яни Гош. Чи розглядається можливість додати в програму використання інших психотерапевтичних напрямків?
Well, I mean, I guess we're always very open to the culture where this program is introduced. For instance, already when it was kind of transferred from Germany to Sweden, we did some cultural adaptations because some methods are just not very accepted or liked in Sweden. And of course, we needed to do some variation also where we went to Australia and to Turkey and to China. So there's always flexibility. But of course, the techniques that are introduced should also have some form of evidence in autism or at least some kind of scientific or clinically meaningful approach. But there is flexibility. I can give you kind of a little anecdote from Sweden. For instance, in Sweden, the coffee break, it's called fika. The coffee break is a very important thing in our society. The coffee break is always where where really the social life is happening, and where the discussions are, and where the decisions are taken. So actually, we introduced some kind of this coffee break into the contact training, just also to make an awareness that this is an important social arena, and that they get some kind of idea how you can act in an unstructured, important social situation. So all of these things are possible. We want to be realistic when doing this program.
Пані Ксенія Лаптєва питає, наскільки доречно використовувати у діагностиці аутизму тест AQ, Autistic Spectrum Quotient?
For people who may be not familiar, that the AQ is a questionnaire. It comes in different length. It's an instrument that comes from Simon Baron-Cohen, is a well-known researcher from the UK. It is the AQ is an okay instrument. It's not necessarily operationalizing the diagnostic criteria for autism. So it's not an instrument that operationalizes diagnostic criteria. It's rather trying to assess autistic traits also from an autistic perspective. So I think it's a meaningful instrument, but it's not operationalizing diagnostic criteria. So you need to know what you're doing. So I think it's a good complement when you're doing a diagnostic assessment, but it cannot replace that you really carefully check diagnostic criteria and use rather instruments that are trying to operationalize those criteria.
Пані Ольга Виходцева питає, чи може бути розлад дефіциту уваги та гіперактивність коморбідним з аутизмом?
Well, definitely. I would say in Sweden, I would say about maybe half of the people who get an autism diagnosis today also receive an kind of diagnosis of ADHD, mostly of inattentive kind. And I think it's done in many different countries that you often have those connections. In the other directions, a little bit less. So maybe 20% of people who have an ADHD diagnosis who also have an autism diagnosis. But definitely, it's a quite frequent co-occurrence to a degree that some people today think maybe autism and ADHD, the kind of a really mixture, almost balanced mixture of the two, maybe should deserve an own diagnostic category. People are sometimes talking about a kind of ADHD. So kind of it might be in the future that a mixture of the two maybe justify an own category. So there is an overlap. Sometimes you can have a real kind of a mixed picture of it, but there are indeed also kind of very prototypic cases of ADHD and very prototypic cases of autism that have almost nothing to do with each other. Traditionally, the ICD-10 teaches you that you should not be doing kind of these double diagnoses, and that has led to that people have been quite reluctant in doing it. But I think for quite a long time now, clinicians are very frequently doing this. So yes, there's overlaps, but you also can have the prototypic variants.
Пан Андрій Карачевський питає, чи є дослідження, які порівнюють різні методи допомоги дітям 5-10 років та демонструють, які методи більш ефективні?
At the age of 5 years, so that's preschool age, and that age mostly what is recommended is some of applied behavior analysis, where you try to find out what are the skills that the children has too few about when it comes, I don't know, for motor skills, social skills, skills in daily living. You try to identify those, and you make a priority of them. And often you try to find the best to try to find which kind of reinforcement is the best way to motivate the child to be better at those skills. And you try to introduce motivating situations, and you try to motivate the child to do actions that are like those skills that they would need to learn. And then always when they show this behavior, you are reinforcing them with something that motivates them. And so you're trying to build skills one after another. That's principles of applied behavior analysis. And there are many different programs for doing this, mostly coming from the United States and the UK, and there are also programs that are kind of specialized for home settings or preschool settings, and well, it's more traditional behavior modification based on learning theory. So I think you can, if you would read this publication that I mentioned in the beginning, the Autism Lancet Commission, I think you will find a lot of valuable information just kind of tackling what can be done mostly in preschool children in that arena.
Пані Галина Несмашна питає, якщо дитина з розстройствами аутистичного спектру має дуже обмежений вибір продуктів харчування, як можна збільшити варіабільність її раціону?
Very limited what? Can you repeat?
Має дуже обмежений вибір продуктів харчування. Як можна збільшити варіабільність її раціону?
Okay. I get it. So probably this is about kind of selective eating, which is quite kind of a frequent phenomenon, that autistic children maybe are very selective in what they want to eat. They maybe prefer only kind of very sweet things, or very kind of salty things, or fatty things, or of a certain color, and this often means that there's a certain risk that they have kind of malnutrition. I guess the most important thing is always that they get their calories, and that they and then I guess there's also a possibility to do something with food additives. But of course, I guess the most important thing is that that it is clear, for instance, in the family, if possible, that you have actually routines around the meals. So I mean, it's the family sitting together, and there's a certain range of things that are offered, and the people who are around the table are eating this, and that you have those routines in kind of very kind of modern societies. We have a kind of a very in Sweden, for instance, we have families who do not eat meats together anymore, who everyone eats his own little kind of sandwich or protein drink. And so I guess it's important to establish kind of family routines about the eating, and that the family is preparing the food, and that you always try to introduce new foods, and that you never give up on this. But of course, the most important thing is that children eat something at all, so they get their calories, and from there you should be trying to motivate children to try to do new things, and not be too worried about it in the start, but getting in the calories, and then slowly trying to introduce kind of new things, and trying to have a good routine about the meals, and not letting everyone kind of eat their own things in different times in different places, so that meal routines have a standard, and it's clear what is eaten by people, and not fighting about it. So it's important that you choose your fights with children, and that you have those fights when they're most important, and otherwise try to build a good relation. Children who have a huge trust in their parents will also maybe have a higher likelihood of trying new food at a certain point in time.
Пані Остапчук Вероніка питає, наскільки залучені батьки до програми «Контакт», на який вік вона розрахована?
Yeah, so the age groups we have children's groups that are kind of 8 to 12, And then we have adolescent groups 13 to 18. There's a little type of variation depending on the degree of development of those children. It's also important that you get a good kind of composition of the groups. The first question was, it was age and...
Чи залучені батьки до програми «Контакт»?
I have the parents, of course. Yeah, yes, they are indeed in the long. So we have different length. The shortest program is 12, and then there's intermediate version of 16 meetings, and the long one has 24. And in the long one, you have 6 parent meetings, where the parents meet up and you try to explain what the program is about. You try to motivate the parents that they help their children to complete the program in the best way. That mostly is, well, trying to telling the children kind of what is part of the program, trying to motivate them to do their homeworks, trying to remind them, trying to also to motivate, especially in the beginning, to try the program. So they have a quite important role in interaction with the child and trying to help the trainers that the child is showing maximum participation in the different elements of the program, especially in the start. And then, of course, there's also an element that parents meet up in that group so that parents get some kind of, they can have an exchange around how they help their children and what's working out. So there's also kind of a peer support among those parents, and they meet each other 6 times during those 24 meetings. So yes, you cannot do it without it. In the adult programs, you often want to reduce the amount of parents or other people, because you say, well, adult people also need to find a way to motivate themselves.
Пані Юлія Віхрова питає, з якого віку в Швеції розпочинається діагностика аутизму? Чи звертають увагу на стан дитини педіатри, сімейні лікарі, і з чого взагалі починається діагностика?
So we have diagnosis before the age of 4, but it's not super often. I think it is really only in the cases where you have other things in the picture, like genetic syndromes or intellectual disability, or kind of or when you have children who do not start, so showing kind of verbal behaviors or nonverbal communication. Those rather severe cases, people often get diagnosed at the age of 3, but that's a little bit of a minority today. Most of the children get diagnosed when they enter school. We have a lot of children are entering preschool, and preschools have a very, very kind of tolerant and approach to behavior variability, and it's very rare that preschool teachers refer to clinical services. So it happens, but it really happens only in the very clear cases that children are diagnosed at the age of 2 or 3. And we have previously we have had specialized centers for this early diagnosis because it is different from diagnosing children in school age, because often you're really going mostly on developmental level, and you're going on symptoms. You do not have so strong less stronger indications of really the impairment. But it is done mostly at the age of 3 in severe cases, and it often includes it includes a home visit. Sometimes we have the Autism Diagnostic Observation Scale. You have family history or kind of child history interview, and you do an assessment of the developmental level. So in the young children, there's a little bit more diagnostic made, and in the older children.
Пані Олеся Редик питає, який метод терапії до дитини вам імпонує більше – Floor Time чи ABA?
Well, kind of in the tendency more ABA, but I like, of course, the new variants of it. So I like, for instance, naturalistic teaching. I like naturalistic teaching because it reacts to the children's behavior. So you need to have a little bit of patience, but you're following the child, and every time the child generates a situation where it's adequate to introduce this learning opportunity, or when you see a behavior that the child naturally shows that you would like to reinforce. So kind of naturalistic teaching, really trying to generate to be very aware of where the child is showing some kind of behavior that you want to reinforce. That I think that's quite important. Naturalistic teaching, not discrete trial training. So not the more traditional variant where you really kind of try to very massively trying to focus on the child and direct the child extremely heavily. That I would only do if nothing else works, or to build maybe the first step of the child's behavior. But whenever possible, I would like to use, approaches that are more kind of naturalistic, or where you generate an environment that is so attractive to the child that the child naturally wants to show things, and then you go and reinforce, so that there's not an atmosphere of forcing or manipulating the child, but kind of more things that are natural. In that case, I'm far more in favor of ABA when it's done in this form.
У нас дуже багато питань, я з них задам ще 3, бо вже дуже пізно. І задаю ці 3 питання, і ми на цьому зупиняємось. І так, питання від пані Оксани Мельник. Як у вас працює реабілітація? Бо у нас часто ставлять акцент на навчальних досягненнях, забуваючи працювати з емоційним інтелектом. Як у вас відбувається ця корекція?
So in Sweden we have something called rehabilitation centers. So not rehabilitation, but habilitation, because the idea is, for instance, autistic children, they have not lost skills, but they need to learn skills that they have never had. So trying to rebuild skills from the scratch. And because we also have capacity issues in Sweden, we do mostly 2 things. On the one hand, train people, professionals who work at the rehabilitation centers. They train preschool staff in how to employ early intervention, mostly naturalistic teaching. So there's some kind of, they have the specialists at the rehabilitation centers that try to facilitate that early intervention is done in preschools. So trying to build capacity in those places where the autistic children are in their more natural environment. And the other thing is that we have a lot of parent training. We have courses, so where we try to teach parents quite in huge quantities in courses. So trying to skill up the parents, even here the idea of capacity building. And then there's a lot of online resources available. So because we have so many cases here at the moment, the rehabilitation centers who are mostly responsible for kind of skilling up the children and the parents and the environment. That's we are trying to do it by generating capacities in those places and among those populations that are kind of naturally close to the children and see them every day. So it's not so much individual teaching or individual intervention that experts do who are highly qualified with each child. So it's more building capacity among those people in the places where the children are. That's how rehabilitation works in Sweden.
Пані Анна Бабкіна питає, як у вас з допомогою дорослим, чи діагностують легкий аутизм, як от розширений фенотип аутизму?
So is this a question about how diagnoses are made in adults? I'm maybe not getting it completely. Yeah. So well, I think there are differences still between how child and adolescent psychiatry works, at least in Sweden, and how adult psychiatry works. I think there's still some kind of both limited kind of knowledge and skills, and maybe also very different tradition in adult psychiatry. We have still a limited amount of people who are feeling themselves qualified to make an adult diagnosis, and there's always the question a little bit of what's the overlap between autism and personality disorders and maybe residual schizophrenia. And often other things are overshadowing autism, like, for instance, a kind of a chronic depression or so. So I think if you are not having the possibility to do a good history taking, and if you are not having access to relatives and maybe parents to do a good history taking, and the person, him or herself, is not able to report, then this can be a complicated situation. But if you can do history taking and you find that there is a kind of a history that is consistent with your hypothesis of autism, I think it should not be so complicated. That there are differences between autism and personality disorders, and there are differences between autism and other things, but it needs a little bit more skilled diagnostician. I think it's very valuable when you have been working with children and adolescents in different ages across functional levels. Then I think you're far more able diagnostician even in adults than when you only see adults.
І останнє питання сьогоднішнього вечора. Пані Марія Маринчак. Якщо дитині встановлений діагноз розладу аутистичного спектру, на яку соціальну допомогу претендує така дитина в Швеції?
Oh, there are many different ways. So we have of course we have social services where you can get a lot of support for your social life. There's possibilities offered for the children to get some kind of more adequate or kind of more meaningful kind of leisure time. There's help for parents that they can, for instance, get time off their children. Especially autistic children have in general the access to it's very hard to translate, but we have in Sweden the participation law, as there's also in Germany, where you can get a lot of things to try to get compensation for the disability that you have, everything from transport to kind of personal assistance and so forth. So there's a diagnosis of autism qualifies for a lot of social support. Even try to get transport to school or transport to the clinical setting. Also, you know, that you get fees for to compensate for extra costs that you have, and so that is quite developed, and it's called LSS, and it's a participation law. It's quite extensive, and Sweden was among the first countries to launch such a law. You have the idea is you should be as much as possible be able to get compensations for the disability that you have, and that's across ages. So, but at the moment we see, because there's so many diagnoses, we also have ceiling effects. So it's a little bit more difficult today than previously to get all these compensation mechanisms.
Дуже дякуємо, Свен, дуже дякуємо, Jörg і пані Оксана. Якщо ви ще щось хочете сказати в кінці, будь ласка. Від себе скажу, що я не встигла представитись на початку, бо в нас була замінка технічна. Мене звати Катерина Булавінова, я медичний експерт дитячого фонду ООН UNICEF. І дуже дякуємо всім вам, хто погодився в вечірній час бути з нами на цьому зумі. А вас було десь 400 людей, навіть трішки більше на зумі. І ще багато людей було в Ютубі і в Фейсбуці. І ми дуже вам дякуємо за те, що це був такий активний чат, навіть всіх питань не встигли задати. Тому, якщо пані Оксана, Йорг, ви щось хочете сказати, будь ласка, кажіть, і будемо закривати цей вебінар на сьогодні.
Я хочу додати лише більше магічних слів «дякую». На мій погляд, це найресурсніше слово, яке є у спілкуванні між людьми, тому що воно дає багато енергії. І я дякую всім учасникам. І для нас кожен такий вебінар – це ознака того, наскільки необхідно мати доступ, яка велика потреба в доступі до сучасних знань і до можливості обмінятися якимись думками між фахівцями. Дякуємо, професор Фегерт, за те, що в нас така можливість з'явилась в нашому такому спільному проєкті. Тому, будь ласка, всі бережіть себе.
Thank you very much. Bye.
Goodbye and thank you. Bye.
Дякую, до побачення.
Пані Катерино, величезне вам спасибі. І команді.
Спасибо всім, thank you all.
Щиро дякую, до побачення.